And the first one, I think the easiest one that everyone's used to hearing about is funding. Since we are not federally funded or state funded, and we rely on donations from the community and grants and foundations and private donations, a great deal of private donations as well, finding the time to go out and raise some more money for HIT proves to be very difficult for free clinics, especially in this current market, for lack of a better word, with all of the conversations about universal health care reform and with the conversations about, well, the stimulus package gave a ton of money to you all, then most of the foundations, we have to educate them and say we're not qualified, we do not qualify for that. So raising that money takes a lot of our staff time to do that, or our volunteer time, and it's proven that it doesn't work for us. So we support two pieces of legislation that were introduced in the House and the Senate, and both of those pieces of legislation will open up some grant funds for free clinics and other safety net organizations that did not necessarily qualify for the HIT funds, but as you can imagine, those are tied up in so many committees at this point in time that we're looking for a very long time before they could go any farther. I think for us, another barrier to adoption would be our workforce. We primarily utilize volunteers at our organization. We do not have an IT person. And to put this all in perspective, I'm the entire National Association of Free Clinics. We don't have a staff, we don't have anything. So our clinics operate very much in the same exact type of way. So there is no IT person. There are tons of universities and public companies and private companies that come and support us, but they're not going to be there every single day while this is going on. And also education and computer proficiency levels will vary depending on where you are. We have some student-run free clinics that are going to be great at something like that. We have a great number of free clinics that utilize retired volunteers, and so there is a very big difference. So training is going to be a very big issue for our clinics, and I think across the board you would find that training on a computer system is a little different than training somebody to come in and say, welcome to the clinic and how are you doing today. One that we talk about a great deal and I get questions on a lot is our patients are going to be a barrier to adoption as well. And I don't think that's something that has been thought about in the past. Since our patients are shared between many of the different agencies that you're going to see at this table. Our patient will come to an emergency room, and we'll start at the top, and the emergency room will either help them find another facility that they could go to, any one of ours, or the patient will come to a free clinic. They will stay with the free clinic for 6 or 7 years, and then they do qualify for some sort of service. We will send those patients quite happily to one of the places that can help them, that does have insurance. Well, sharing that data between the two is really an interesting place because free clinics operate under different requirements under HIPAA or OSHA or different ways than some of our other groups, and how they talk to each other. We'll get into that a little further on. How the systems talk to each other is something that's going to be a concern. Our patients get nervous when they move from what is considered their medical home to another place. So they are going to ask for their records, and they are going to show up wherever they are with a stack of records. And then the question is, well, we just want these electronically from you, and the poor patient doesn't understand what that means at all. We will have to spend a lot of time educating our patients. I was just explaining a story that happened. We had a clinic who put an EMR in, and we had done town halls, and I had traveled there 3 times, and we had told their patients what this meant. And when the day happened, a 3-hour clinic actually ended up being a 7-hour clinic, because when they sat down and they saw a computer and they wanted to know, now what are you doing again, and why are you typing in my information, and who is this going to? Even though we had educated them beforehand, it still was a concern. Health literacy is a big issue as well. It goes along with the education, but I was explaining that we say welcome in some of our clinics up to 17 different languages just to say welcome. And so educating with health literacy is going to be a big issue. And very frankly, there are migrant and transient workers and patients that use our healthcare system here in the United States. And the cell phone number you might have had for them yesterday may not be the cell phone number that they use today. If they're homeless, then the address of the shelter that they used 3 times ago, they can't stay at that shelter any longer. So that is a concern when it comes to meaningful use of a system. If you don't have good data, then the system doesn't help you either in some ways. For us, I think educating your board and the for-profit sector is going to be a very big piece of adoption. Explaining to our board why you're going to spend $10,000 on a program, and that's a very low program for in general, what we're talking about. Or you could spend $10,000 and get all of the glucometers and medical care and everything that you need to service that patient right that minute. Takes a long time. Explaining to them that having an EMR will help them in disasters or transition patients or doing all the things that we know it's good for, or giving them a tangible result that they can look at that patient the next day and say, look, your blood sugars are down because of this glucometer, will take time. One of the biggest things we're having time with and a hard time with right now is because of the stimulus funds, the companies that have EMRs are going to free clinics and saying, but you have all of this money in the stimulus bill, and you can actually use it to purchase an EMR. And then the clinics get all excited, and then when we have to go through and tell them, no, you don't qualify for that because that money isn't for you, and this is what it will cause. It causes a couple of problems. One, it causes distrust. It causes a lot of distrust of companies out there that say, why are you telling me this if it's not true? And it lets down, I think, the clinic's ability to continue to function the way that they need to for their patients. And as I talked about before, compatibility of data, to make sure that the same information that I want is the same information Ruth wants, and the same information that you want, and the same information that HRSA might want, is something that is a big question mark in our head. How do we decide that? Who decides that? Who gets to say those things? And along those lines, in my closing thoughts, I think communication and training as well as education are going to be very, very important for adoption. But I also think continued benchmarking of the process is necessary to make sure that those who have the money and the ability, because you're hearing that we're from the safety net, that may not be the same, do not go so far ahead of the process that we're left so far behind that this population doesn't have even a shot to get the right process. So I think we're going to need continuous benchmarking throughout this whole entire process. And we look forward to working with you and our partners in this area. And thank you very much for having us.
Great. Thank you very much, Nicole. Now I'd like to turn over the clicker, you would call it. Click it again. The green. There you go.
Thank you.
There you go. To Yvonne Claudio, who's the CQI coordinator for Ambulatory Health Services at the Philadelphia Department of Public Health, and she'll talk about some of the needs from the city and county hospitals and facilities perspective. Yvonne.
Thank you. Thank you very much for having us and giving us the opportunity to present on the local health department safety net and to make sure that we are assured a role in the HIT and interoperability initiatives. I'm speaking on behalf of NACHO, the National Association of County and City Health Officials. NACHO represents approximately 3,000 health departments, local health departments across the U.S. They promote national policy on behalf of the health centers. They develop resources. Oh, we went too far. They develop resources and programs on behalf of the local health departments, and they support effective local public health practice and systems. I want to give you some background information. We are a safety net provider. We are there providing medical health services in medically underserved communities. The population that we serve has been described by a previous speaker. It's the Medicaid covered, the vulnerable population. Vulnerable population, mobile, chronically sick, inadequate access to health care services. They face many barriers in accessing care, the language barriers, the cultural barriers, the barriers that relate to trying to navigate the health care system, and experience major disparities in health status and quality of care. The fact that health departments have health centers within their purview is very much aligns with the public core functions and essential services. It relates directly to the assurance core function, and within that function, we are required and mandated to link people to needed personal health services and to assure the provision of health services when they're otherwise available to our population. By way of example, I work with the Philadelphia Department of Public Health. We run 8 federally qualified health center lookalikes. They're located in the poorest communities of the city, in the medically underserved areas. In terms of the city's stats, we have about approximately 1.5 million people. A quarter of those individuals live below the poverty level. So we're serving about a quarter of the people of the city's poorest residents. And we have 80,000 patients that we see. This next slide shows you the extent to which local health departments across the country are providing primary care services, and it's presented in relation to the size of the population within their jurisdiction. So you see that as a health department's area of jurisdiction is larger, they're providing a greater percentage of primary care services. So about 11%, or about 260 local health departments, are providing primary care services. I've entered some guesstimates on this slide as to try to get at how many health centers are we actually running within local health departments. I think the accurate number is somewhere over 1,300 health centers. The next slide shows you the additional health services that we're providing in addition to primary care services. So over 2/3 of the health centers are providing family planning services, prenatal care, and oral health is provided to a great degree, as is mental health services, substance abuse, and home health services. On the public health side of the house, we also provide a lot of services that are utilized by the medically underserved population. A lot of the immunizations, the lead screenings, the nutrition service, substance abuse, and so forth services are directly utilized by the medically underserved population. I want to move to a discussion of the HIT of relevance to local health departments. As with other clinical services, we are relying on the various solutions that are presented here. When people talk about the electronic health records, there are various components to that electronic health record. It is not merely the EMR. There's the e-prescribing, the pharmacy system, the automated lab systems, and so forth. And these are all components that, if they're not accounted for in the HIT project, will cause barriers and challenges in delivering care. I put the pictures that I included reflect what we're actually dependent on in many cases, which is paper records. We have medical records, we have progress notes, paper progress notes, we have paper scripts, we have paper post-its, we have paper logs, and this is how we operate. It would be nice to have some of these, and in some cases, the practice management system may be available within the local health department's health center or in other health centers, but it may be a dated system that's really not meeting your needs at this point and really will not interface with the electronic health record or the electronic medical record that you're thinking of implementing. On the public health side of the house, for local health departments, we have all these systems that are just as critical.